Good evening. I'm Tom Duchesne. I'm a researcher here at the Goodman Cancer Research Center and in biochemistry. And it's an honor for me to be your host tonight. This series, meaning and purpose, is essentially about the link between knowledge and hope. Hope because when you know how things happen, you can target it, you can do something about it. Same degree that something you don't understand gives you fear, something that you do understand better actually gives you hope. Hope also because the Goodman Cancer Research Center is heavily structured around collaboration. Science in the past actually was structured in silos, people trying to outdo each other, whereas now the center is structured and people actually recruited in the center on the very basis of collaborations. And the series is actually based on that structure. You'll hear amazing researchers from the MUHC tonight, from also the Lady Davis, the Jewish hospital. But we also had participants from all the institutes in Montreal and sometimes abroad. So we've learned over the years that cancer is a formidable opponent, and that only through collaboration can we actually hope to fight it efficiently. So that's why we call this series A Reason for Hope. So I'll be your host. I'm a researcher here. I'm a professor. I teach. Usually I see a bunch of really awoke students in these audiences. Some of them are going into med school, some of them going into research. And it's always a pleasure for me to sit in front of young and talented people. But it's also quite amazing for me to let you know about what the latest advances in research are, both at the bench but also at the bedside. And that's what's reflected in our program tonight. Today's topic is weight loss in cancer patients, and we're going to explore together the clinical implications of loss of weight, but also weight management on treatment outcome, and also quality of life and survival. So one word that you probably heard associated with this topic is cachexia. Cachexia is a formidable loss of weight, but I would say that I think statistically about half of the patients actually are affected in one way or another by a weight loss during either cancer itself or during the treatment. So it's a broader topic, and tonight we'll actually cover more than cachexia. We'll talk about how to manage weight in the broader sense of the terms and how it impacts treatment and outcomes. The overview of the evening is, first we'll hear about, we have really formidable speakers tonight for you. I'm really excited about the lineup, both during the presentations and in the panel. We actually have other researchers coming and joining during the panel at the end, answering your questions. First presentation will be by Dr. Thomas Jago. He's Associate Professor in Oncology Medicine here at McGill, and he's also Program Director of the Cancer Nutrition Rehabilitation Program. Second talk will be given by Stephanie Chevalier. She's Associate Professor in School of Human Nutrition and Associate Member in the Department of Medicine. And she is also a scientist in the Metabolic Disorders and Complications Program at MUHC, the Research Institute, which is at the Glen site. I'm sure you've heard about it. And finally, the last presentation will be about my colleague and friend, Imed Galuzzi, here working in biochemistry and also at the Goodman Cancer Research Center. And Imed will actually talk about the very frontiers and the topics that actually are explored. On one hand, to identify new biomarkers and anticipate how the disease will progress and what kind of disease we're facing. On the other hand, try to identify new targets for therapy, new strategies for therapy that will actually represent the future of weight loss treatment and management. We'll hear testimony tonight. And for me, this is my third forum that I facilitate. It's always a very important part of the forum. And you have people that actually went through it, come and tell us their personal stories. And if you think about it for a second, this is a very, very generous move. Come here and tell you about one of the most challenging moments in their life and how they actually went through it, and so that they actually can give you hope. So I'm really grateful that Mr. Andrew is here tonight to do just that. So we'll actually have a short interview with him. And finally, we'll gather all of your questions. I'll explain the functioning in a few minutes. And 5 panelists will actually join this table here, and we'll go through all of the questions that you have. So the presentations will be given in English today. But at any moment, if you have questions that you want to ask in French, I will answer. Most of the panelist members speak French, and we'll find a way to get you an answer in French. There's no problem. The weight functions for the questions is you will have little cardboards. Some of you are actually used to it. We'll have white cardboards where you can actually write your questions at any moment during the presentations. We ask that some of the volunteers will actually catch those little cardboards during the presentation. We ask that you keep your questions for the end so that we can ask them to the panel, and so that they can actually debate, or whoever has something to say can say it, but also everyone in the audience and also over the internet can benefit from the answer. And don't be shy. It's on cardboard, it's anonymous, and the questions, I'm always amazed at the quality of the questions that are asked in those forums. So please ask away those questions. We'll take the time to answer. And at the very end, the panelists will actually stay here for a little while. If you want to come and meet with them in person, you're welcome to. So on this, I'm going to move forward with the first talk. We're really grateful for Dr. Thomas Jago to be here tonight.
I'm very pleased to be here this evening to talk to you all, and hopefully I can set the scene a little bit for my colleagues who are going to talk about some of the more detailed studies that are ongoing or have been done. So I'm a clinician. I am a respirologist by training. I work principally at the Jewish General Hospital. But as Thomas was saying, I'm actually director of the McGill Cancer Nutrition Rehab Program, which is a program based in the Department of Oncology, which has a couple of satellite clinical teams, one of which I direct at the Jewish General Hospital. And I'm pleased that Christina, who's our senior dietitian now, is also going to be here this evening, will help answer some of the questions. So what I'm going to try and do is set the scene a little bit in terms of our experience with patients and try and tell you some of the stories, some of the problems that patients come across, and touch on some of the studies that have been done. So if we can just focus a little bit for the moment on this issue of weight loss in cancer, one of the things that I think needs to be stressed is that it's very common, particularly in advanced cancer patients. And it's a key feature of what we are going to talk about. So weight loss in cancer patients is very common, particularly in advanced cancer patients, and it's one of the key features of something called the Cachexia Syndrome. And hopefully by the end of this evening, and perhaps by the end of this talk, you'll all have a slightly better sense of what we mean by that syndrome. But it's basically that your patients with cancer who are losing weight are usually not just losing weight. There are other metabolic and functional changes that are occurring, and some of those changes can be occurring and are sort of hidden, and they're not very obvious even to the patients themselves. And unfortunately, weight loss as a phenomenon, and the syndrome of cachexia actually identifies patients with cancer who are at increased risk. These are patients that often don't do as well as other patients, and so they often need extra help. There are a few things that have become clear over the years, and one of them is that different cancers have got different patterns of weight loss, and this is a summary slide from a review from last year. And on the over here you can see, I can't see, but you can see some of the cancers like pancreatic cancer, which typically at presentation 2/3 or more of the patients have lost weight by the time they get to know of the diagnosis. Whereas at the other extreme, patients with breast cancer, and particularly cancers like prostate cancer, weight loss per se is less common. Not to say it doesn't happen, but it's less common. Now, much of what you've heard about weight and health over many years is that being overweight is a bad thing. And so there was a sort of uncertainty which has arisen in the field about, well, if I've got cancer and I'm overweight, is that a good thing or a bad thing? And is it the weight that I have which is important, or is it how much weight I've lost which is important in terms of defining this increased risk? And we were contributing to a study which was published recently. This is a cohort study of about 6,000 or 7,000 cancer patients of different types and different stages. And what we did was we grouped all those patients together, and we looked at their outcome in terms of their survival. And if you look on the left side here, this is weight loss. So the patients in this area had lost very little weight, whereas the patients down here had lost 15% or more of their body weight in the months prior to diagnosis. If you look across the top, you can see the same for BMI. So let's just focus on the weight loss. And you can see here, these numbers are the average survival time for those patients in that group. And so the patients that were weight stable or had lost a relatively small amount of weight had a median survival in the region of 20 months, whereas those that had lost a lot of weight had got a median survival of only 7 months. So this was telling us that weight loss, the more weight loss there was an increased risk here. And when we looked at the BMI, you could see that those people that had a higher BMI were protected. They had a higher survival rate, whereas those that had a lower BMI, which is a measure of your weight relative to your height, they had poorer survival. And when you combine those two, which is what the effort was in this study, you went from patients who had a median survival of over 20 months down to those here who'd lost a lot of weight and had very low body mass, who had a median survival of only 3 or 4 months. So even in modern oncology, this was a recent study, even in the era of modern oncology, we can see that there's a way of combining weight and weight loss. And it seems that in this sort of situation, that being a bit heavier and not losing weight is a bit protective, whereas if you've lost weight and you haven't got much weight to start with, you're in quite a high-risk group. I'm going to come back to this idea about weight a number of times during the talk, but that's just to sort of set the scene. Cancer cachexia, this syndrome of weight loss with other changes in the body, is now pretty well defined, not as well defined as we would like. And this is a sort of consensus document that came out a few years ago, chaired by the late Ken Fearon, who was a real clinical champion. He was based in Scotland, a clinical champion for this problem. He was desperately pushing forward the boundaries in terms of trying to help patients with this condition. And with colleagues, they managed to define the criteria for people who were in so-called pre-cachexia, so they had signs that they were starting to lose weight or other changes consistent with that syndrome. And the patients with clearly cachexia, and those were ones with more than 5% body weight and other features. And then a group of other patients who had lost weight and had other metabolic changes in whom it was becoming rapidly clear that it was more difficult to treat them. So what is the impact of this syndrome when we actually talk about it in general terms? Well, it seems that the mere fact of the weight loss and the metabolic changes that go along with that is actually causing death in some patients. 20 to 30% of cancer deaths are attributed to cachexia. It certainly limits treatment options, and I'll come on to some of the reasons why that is later. And some of the toxicities that you get from treatment seem to be higher in those people that have lost a lot of weight or suffering this syndrome. Because there's associated muscle loss and weakness, people are often functionally, meaning they're not able to do the functions that they would normally do. They're less independent and perhaps more vulnerable and fragile as a result. And there are a number of very distressing symptoms which are associated with having these changes in the body. That's all bad, but it also opens up an opportunity, which is that if all of these things are bad, then maybe this is an opportunity to try and improve things. That if we focus on why this is happening and what's going on, then maybe there's a real opportunity here to improve outcomes, to improve how people feel, how they function, and possibly even improve their survival if we can find ways to address this. So these are the sort of features that we see. For some of you, I'm hoping this is a familiar. Patrick Swayze, a big-time movie star, dancer, and theatre actor. So this is him aged mid-50s in 2006. He's standing outside a Broadway show, which he's in. And he was a very athletic, vital sort of actor. And this is him a few years later. I think it's only 2 years later. After diagnosis with pancreatic cancer, and you can see some of the features. He hasn't just lost weight. He's also lost muscle mass. He's lost function. You can see him bending over trying to open the car. He's lost that ability, that flexibility. And this is what it looks like. These are the changes that people suffer. And if we try and group that into the problems or the types of syndromes that we see, or the parts of the syndrome, we can see certainly there's loss of weight and often loss of muscle mass and weakness. There's anorexia, often accompanies with this, which means that people often don't have that desire to eat that they had before. They don't have the same enjoyment, and it's often associated with fatigue. They can be related to that reduced dietary intake. It's not just don't want to eat, but they're actually not getting enough fuel and protein in the diet. And they have this reduction in exercise capacity, this reduction in physical ability and strength, which is a critical feature. Why is this? Why is it occurring? What's going on? One of the key points that I want to try and get across to you is that what is going on is certainly not simple. It is very complicated. We have a much better understanding of it than we did some years ago, but it's still evolving. And it's certainly not something which is going to be amenable to one simple fix. And if we look at it from the patient's perspective, and this is a picture of another famous celebrity, I guess, who unfortunately died of a similar cancer. But you can see that patients may have a variety of different symptoms, whether it's nausea, whether it's anxiety and depression, whether it's fatigue, which make it more difficult for them to seek and achieve some of the improvements that we want in terms of their intake, in terms of their diet, in terms of their exercise capacity. But there are other things going on as well. They may have other illnesses which are pretty well controlled if they don't have cancer, but become much more difficult to control when they do have cancer and they're undergoing treatment. Some of the cancer treatments themselves may contribute to some of the symptoms or even some of the weight loss. So from the patient's perspective, it's really complicated to start with. When we drill down to what's happening at a metabolic level and we look at it in terms of what's actually happening within the body, there are a number of interactions going on. And this is just one cartoon that was pulled from a very good review from a few years ago. So in the middle of this, you can see the cancer. But the cancer is actually communicating, or we think interacting at some direct or indirect level with a bunch of different tissues within the body. The liver, certainly, and changing the way the liver reacts to nutrients and also what sort of proteins it manufactures. It's almost certainly interacting with the brain, and the brain has centers for controlling energy expenditure, for controlling diet and exercise, as well as, it's not exercise, but the desire to exercise, and it may be one of the causes for fatigue. And it also has a key role in terms of controlling a whole host of different aspects of metabolism, but also more peripherally in terms of muscle metabolism, in terms of fat metabolism, probably in terms of all tissue metabolisms. There are interactions going on, and some of those have been described in a lot of detail in certain particular situations, but we're still not yet able to actually define exactly the nature of the changes that are occurring in any one individual. But we're getting some advances and some technological changes which are making some of these things a little bit easier to grasp. And one of the things that's occurred over the last few years is the reuse of some of the CT scans that are being done for clinical reasons, to look at the tumor and to see whether it's responding to treatment. If you take those scans and then you reuse them, as Dr. Vickie Barakos's group in Edmonton, Alberta have done over the last decade or more, you can start to extract other bits of information. And one of the things you can do is track what's happening to an individual over time. So this is just an example, and here you've got a scan, and this area here is the liver. And then if you look at this, this is the same person, but they're just cut at different levels. The scans are different levels. So higher up, lower down, it's a bit easier to see. Can't see this arrow. So here, this is an area of muscle, and this around the outside is the fat that's sitting underneath the skin. Now, if you track this over time, so this is at one point, and then over time, you can see that the liver area has got bigger. Whoops, sorry. because of the activity of the cancer itself, but also the fat on the outside has got much thinner, and the muscle has got much thinner. And they tracked this out, and you can see here, this is the graph of what's happening with the liver, and you can see here the graph of what's happening with the fat, and then here what's happening with the muscle. So as the disease was progressing, there was now a potential to see differences and look at what was happening in individual tissues. When it comes to actually then looking at a group of patients and who appear to be the same, we're now able to see that they're not all the same. And if we just look at this group here, so these pictures are all of 3 different people. They all have exactly the same weight for height, so they all have the same BMI. But if you look at the areas of red here, the red is outlining the muscle, and you can see that this person here has a lot more muscle than this person. So they have the same weight or weight to height ratio, but the person on the right, as you're looking at it, has got a lot more muscle than the person on the far left. Why is this important? Well, it turns out that, I've told you about weight change, it turns out that muscle mass is also a very important contributor. So in this particular study, they looked at, I think, 250 patients with colorectal cancer, and they took a subset of those patients, well, they took the subset of patients was colorectal cancer patients who were overweight. They had a BMI of over 30. And they looked at their scans, and they separated out the people that had a low muscle mass and the people that didn't. And then they tracked them, and they found this, that the people who were overweight but had a low muscle mass had a median survival of only 10 months, whereas the people that didn't have that low muscle mass had nearly a doubling of their survival. So they had a median survival of about 20 months. So looking at the weight gives us a lot of information, but being able to drill down and look at the changes in the tissues, and particularly looking at the muscle changes, seems to give us a lot more. So what can we do? Well, one of the things that we can do is to look at nutritional status, and there are a number of studies, not as many as there should be, but there are a number of studies that have been done that show that giving nutrition, particularly if you start that nutritional intervention early, you can actually stop or head off some of the weight changes. And so this is a study comparing people getting a nutritional intervention. They all had head and neck cancers, and those that didn't. And so these people on this line had the intervention, and these didn't. And you can see the difference here. These people that didn't get the intervention lost a lot of weight during their radiotherapy treatment, whereas the people that got the intervention didn't. And interestingly as well, those patients with the nutritional intervention also maintained better function, presumably because the muscle needs fuel, and if you don't provide it with fuel, then it's going to waste away. In addition, there are some multidisciplinary teams around the world, and we are, I guess, lucky to have 2 here in Montreal working in the McGill hospital system. One of the teams is led by Dr. Vigano at the Glen site, and the other team is led by me at the Jewish General, and this is a picture of the team. And so how do we approach the management of patients with this cancer cachexia syndrome? Well, one of the things that we do is use careful measurement and evaluation of individual patients. As I've said, this is a complicated, complex syndrome, and individual detail is important. So it's very key for us that we actually look at each individual carefully and try and decide what their needs are. We also have a couple of very expert dietitians who are used to working in this field, and I think it's a subspecialist area, so it's not something that a dietitian can necessarily walk into straight away. There are a number of facets to working in this particular field that mean that we do need subspecialty training for this. We also try and evaluate and manage some of those symptoms, some of those things like nausea, like pain, that get in the way of trying to get people to improve. And a key part of what we do is actually incorporating exercise. Well, some people think this is a bit bizarre. If I'm losing weight and you're saying I'm under nutrition, I have inadequate nutritional status, where does exercise fit in? Well, it turns out that exercise is a natural anabolic signal. It's a natural way of getting the body to turn from being in a breaking down sort of mode to making it grow and trying to get the muscle strength to return. Muscles are a key store of protein within the body, and also exercise probably helps return or change some of the metabolic changes that are induced by the cancer. And so pretty much every study that's been done in cancer patients is telling us that exercise is good. And we certainly incorporate that into, and it's a key part of the team multidisciplinary approach that we take. There does need to be some careful balancing, and it's certainly not the case that you can, we recommend that people just run off and do whatever exercise they want. We do try and balance it and make sure that what they do is not stressing the system, and as their nutritional status improves, then we can advance the exercise program. And that exercise program needs to be individualized and it needs to be supervised. We're also lucky that we have one of our members is also trained in traditional Chinese medicine. So for some patients, we also use Qigong, which is a form of exercise. And in selected patients, we actually use acupuncture to help with certain symptoms where it's appropriate. So how do we do? So I'm just going to show you in the last couple of slides some of the data that we've published. And on this slide here, this is just an illustration of dietary intake in the patients that come to see us in clinic. So the patients are referred by different health professionals, and they're coming to us with weight loss. And what we did was we looked at their diet and we sort of just separated it into, this is, inadequate. It's not even going to keep you weight stable, even if you didn't have cancer or any other illness. And that's what we called a poor diet in the red. An intermediate diet is a diet which is sort of okay. It's probably one that would be okay if you were healthy. And then the recommended diet is the one that there's enough protein and energy based on the current international recommendations about those macronutrient intake. And you can see, just as an example here, that at the first visit, nearly 30% of the patients coming to our clinic are not eating enough even to keep them weight stable, even if they were healthy. So there's quite a lot, and by extension, less than 20% are eating enough based on the recommendations. Now, there's a room for debate about the recommendations, but I think it's clear that there's a large proportion of people who are losing weight for a variety of reasons with their cancer, and it appears that a large proportion of those are not eating enough. So whatever else is going on, we should do something to try and correct that. But the correction, as I say, is not just the dietitian, it's not just anybody, it's actually a team that works here. And so with that team approach, how do we do? Well, in terms of people's weight, we managed to stabilize people's weight overall, and that might sound like a little bit of an anticlimax based on what I've said, but if, to put that in context, the people that we see on average are losing nearly 2 kilos every 6 weeks. So over 2 visits, and the visits are approximately every 6 weeks in most people, we would expect people to have lost 3 or 4 kilos, but we overall managed to keep them stable. So we think that shows some effect. We do see improvements in quality of life. And interestingly as well, and gratifyingly, in a subset of patients who are able and willing and commit to doing exercise with us in our facility, we actually get some pretty substantial improvements in their walk distance as well. So in conclusion to this section, just to highlight a few points that I've covered. One of them is that weight loss is very common, particularly in advanced cancer patients, and that indicates probably that there's Cachexia Syndrome happening, and it certainly highlights that that patient has got an increased risk of poor outcomes and that there needs to be extra attention around that. Many different things are going on, and there shouldn't be any attempt to underestimate the complexity of what causes weight loss, and therefore how careful we need to be about how we investigate solutions. Loss of muscle mass appears to be very important and signifies a serious increase in their risk. And we believe, based on international consensus and on our experience that it's a combined approach which is going to make a difference, and we think that there needs to be careful attention to dietary intake, exercise and management of symptoms to help stabilize weight and reduce other effects of the cancer cachexia. There are 2 McGill CNR teams, and we have expertise and experience to help patients, but there's still a pressing need to find additional approaches which can supplement what we're doing and make the difference where our approaches are not effective or not as effective as we'd like to be. And the results of some of the major recent trials and ongoing trials and some current laboratory research is going to be the subject of the following talks. Thank you.
Thank you, Thomas. Our next talk will be by Stéphanie Chevalier. Stéphanie Chevalier, she's is a professor and actually researcher at the School of Human Nutrition and Department of Medicine and at the MHDRI, right? And Stéphanie will tell us on the importance of muscle, in part the insight of coming from the clinical trials. Thanks for coming.
Thank you for this kind invitation. I feel honored and actually privileged to be talking with you tonight and hopefully exchange a bit on your thoughts too. So it's my pleasure to follow up on what Dr. Jago introduced nicely, and you will hear some of the same messages maybe, but that's good to hear it twice, I think, for better retention. So cachexia, as you just learned, is a complex syndrome, but it's particularly characterized by this dual contribution of changes that are happening in the body and also reduced food intake. And this figure shows that merging of those 2 triangles, those 2 conditions, really illustrates that there are various degrees of each contributor, and sometimes we don't, well, most often we don't know exactly what is the contribution of one and the other. So for instance, a patient with advanced lung cancer may have substantial metabolic changes, but not so much reduced food intake, and we do see this happening. And on the opposite side, we may have a patient with a pharyngeal type of cancer, which will then impede a lot the food intake because of obstruction or difficulty swallowing. So that's going to be less metabolic changes, but more of the reduced food intake leading to malnutrition. So the drivers of these 2 conditions, as you see here, well, inflammation is one of them for sure, and catabolic factors, so factors that can be secreted by tumors or by the body in response to the presence of a tumor. And that will affect our brain regulation of appetite. It's in our brain that we feel hungry or we feel that we're full and we have to stop eating. So here the term anorexia does not mean the typical anorexia nervosa that we see typically in younger women. It means decreased feeling of appetite that's regulated in our brain. So those will, as you can see, affect both factors, leading to muscle and fat loss, eventually weight loss. And as we heard before, most of the problems related with weight loss are actually related with the fact that muscle is lost. So you've heard about survival, you've heard about the fact that if we have less muscle, we have less strength, and we're less able to function normally, do our normal activities of daily living. So that talks to losing independence, autonomy also. So that has great impact for patients. It can also lead to more anti-cancer treatment toxicity, as we heard, but it can also reduce our immune response to the presence of cancer itself. So if we have low muscle and poor nutritional state, poor protein status, it can lead to reduced immunity as well. So that's another bad consequences. So among the factors that are contributing to muscle loss, among the triangle that refers to metabolic changes, what we have characterized is an increased catabolism. So more muscle tissue is being catabolized, and therefore will be degraded and lost. Some of the products that are released after that catabolism can actually be recycled, retaken up, but not all of them. So eventually that's going to contribute to reducing the muscle. And the other aspect is a reduced response to normal stimuli that will make our muscle grow. So every time, for instance, every time we eat a meal that contains some protein, we will then turn into a positive anabolic state, meaning that we will build new proteins, build new muscle. And with cancer cachexia, what we've learned is that there's some impedance to that action, resistance to this action. Therefore, we need to provide more protein, for instance, to reach the same level of action. You've probably heard before about insulin resistance. It's typical of what we find in type 2 diabetes, meaning that the tissues no longer respond normally to insulin. And insulin is a hormone that helps building up new tissue, new muscle tissue. So if we're resistant to that action, that also contributes. And on the other side, we saw that low physical activity can actually contribute to muscle loss. We call this disuse, because if we're not using our muscle, we're losing it. And then low protein intake can be a contributor. And finally, older age, which is quite common in advanced cancer. So all of these factors together contribute to the muscle loss. So now, how do we measure muscle? There are different techniques. Some are better than others. This is one that is quite precise. It's became now the reference method, DEXA. You probably heard about DEXA because most of you have done a bone mineral density test, perhaps at one point. So it's also called a bone densitometer. But when you go under that scan, the scan can actually also recognize not only bones, but also muscle and fat tissues. So we can use that DEXA scan to actually look at specifically the muscles in the arms and in the legs. And because the reason why we are particularly interested in those areas is that we know that most of the time we will not see any organ enlargement, for instance, liver enlargements that we saw before, of course, is not confounding what we can measure in the arms and in the legs. And those muscles are mostly all skeletal muscles, so that's what we're interested in. So DEXA is a nice tool to have, but obviously not everybody has access to a DEXA, so we cannot measure everybody and follow up. So the other very interesting tool, as you heard already before, is the use of CT scans that are made routinely for diagnosis of the cancer and follow-up of the evolution as well. And what you can see here is an example of the use of CT scan in the same individual with time, so minus 3 years before that patient passed away. So 3 years before, 12 months before, and 1 month before. And again, using that tracking in time, going backwards in medical charts from patients, the group of Vickie Baraka in Alberta were able to nicely identify the trajectories of muscle and fat tissue loss over time. And this work was really groundbreaking to provide us with a better understanding of what we're dealing with, what we're seeing happening in real life. Now, the other key message that Dr. Jago already introduced, but this is a different way of showing it to you. See, these are 3 different men, so CT scans of 3 different men having esophageal cancer. And what you see here, the first one is a man with a body mass index of 17. So that would be your very thin person, so well below the normal range of LT BMI. The second one is a BMI of 25, so that corresponds to what we consider healthy weight. And the last one has a BMI of 38, corresponding to the more obese characteristics. So what you can see here in red is the muscle, painted in red, and in blue you have the subcutaneous adipose tissue, and in yellow the intra, so the visceral adipose tissue. So if I ask you in the audience, who among those three do you think has the least muscle? What would you answer? So that's interesting. So the answer is that they're all pretty similar in terms of muscle. But think about it. If you were to see those individuals from the outside, you would never guess that with someone who's overweight that there would be so little muscle inside. And certainly the one that looks totally normal weight, you would not guess that either. So when we see a figure of someone who's very thin, we imagine small amount of muscle, but for the others, we don't think about this. So again, we need to look inside, not just measure BMI or waist circumference. It's not telling us everything. And the other interesting point on this figure, if you look at the green color here, that's indicating fat that is actually infiltrated into the muscle region. And that could have negative consequences. It reduces the quality of the muscle. So that can contribute also to less strength and less function. Now, how do we measure muscle strength? That's fairly easily done with a simple instrument that's called a dynamometer. So we can measure hand grip strength or force. So I would ask you to force as much as you can on that device, and we measure on the little scale how much you can force in terms of kilos. The reason why we use this is that you can understand it's very practical, and it also correlates with this muscle strain in the whole body. It's not perfect. It does not tell you exactly of your leg strain, but it more or less correlates. So it's a good indicator. And there are cutoffs for men and for women. We do accept that men are stronger, and cutoffs are different for men and for women. So that's a good tool to use in clinical settings. It's accessible. We also use functional tests to also evaluate muscle strength. So these are, again, simple tests that can be done in pretty much any clinical setting. So stair climbing test, so we actually calculate the time it takes for someone to climb a flight of 10 stairs. We can also do chair rise testing, so the person will be asked to rise from a chair without using their hands to help them 5 times, and we measure the time that it takes to do that. So that's a good indicator of your leg muscle strength, and it's also an indication of endurance, because sometimes you can do 2, but maybe not 3 or 4. And finally, gait speed, so the walking speed over a certain distance that can be measured fairly easily. So these are all very useful tests, because it tells us about, again, the functionality of the muscle. So it's one thing to aim at increasing muscle mass, but we also want to see how that increase in muscle mass can translate into function. And the reason why I'm explaining all of this is that the clinical trials that I will present just now are all based on seeing some changes in these functional tests. Now, moving on to therapeutic agents and medications that are used. Here is a list of agents that are used to treat not cancer itself, but to treat the symptoms that are commonly seen with cachexia. So many of them, of course, have very good usefulness, but we have to recognize that some of them can actually interfere with what we're trying to do, which is to gain muscle and to help muscle function. So for instance, corticosteroids can actually precipitate muscle loss if they're taken for a long period of time. Typically, they're not. So typically, they're used for 2 or 3 weeks to reduce inflammation at certain periods of the treatment, but it's good to memorize that. And finally, some analgesic to control pain are very commonly used, and of course they have to, but they can impede food intake, they can reduce appetite, and also create constipation, which by itself also reduces appetite. So we have to be aware of that. Now, to treat cachexia or to address the loss of muscle mass and muscle function, there have been many drugs that have been tested in all different kinds of studies. So here what I'm showing to you is just a brief list. Actually, it's not complete. It does not include all of them. But you see, the idea is not to remember the names or whatever. It's just to realize that many agents have been tested, and these agents that have been tested so far have not shown any good benefits, and especially when you consider the balance with the side effects that they provide. So that's always, of course, a main consideration when we want to prescribe a drug. It's to evaluate its efficacy versus the side effects. So, of course, we want the balance towards efficacy. Now, there is hope. I'm not going to leave you on that note. There are some agents that have been investigated and are still under investigation to treat cachexia. Those two are listed here. So the SARMs for selective androgen receptor modulators, and the second is the ghrelin receptor agonist. So these drugs have been through the whole process of many years of development, testing in animal models, testing in small studies, and they finally came to that phase where they can be tested in larger, big trials, which we call the phase 3 clinical trials. And the goal of these trials was exactly to try to show an improvement in muscle mass and an improvement in muscle strength or function, and also in the quality of life. So if we look at the SARMs, the drug that was tested is enobosarm. So it's a typical SARM that will be tissue selective, meaning that it will address or act on specific tissues, and on muscle is one of them. So it's been tested in 2 trials, 2 phase 3 big trials. As you can see, 300 patients with lung cancer were part of this trial, and they were split into 2 groups randomly. And one group was receiving the drug, enobosarm, and one group was receiving a placebo. And they continued this for 5 weeks. And after the 5 weeks of treatment, the results showed that lean body mass was improved more with the drug than with the placebo. Actually, the group not receiving the drug actually lost. So again, any gain versus a loss is a major improvement. But unfortunately, they didn't see any major change in the test that was used in these trials, which was the stair climbing test. So that was a big disappointment from, the researchers and the drug company, actually, who produced enobosarm. But it's not completely negative. Again, I want to emphasize that being able to increase lean mass when people are actually losing weight, and that in 5 weeks, is quite a good achievement. Now, the other drug that has even more promising effects is the ghrelin receptor agonist that's named Anamira. So ghrelin, to start with, is a gut hormone that we all secrete in our stomach. We all secrete that gut hormone, and it acts on our brain to actually stimulate appetite. It's, so far, we know the only gut peptide that does that, actually. So anamira is a selective ghrelin receptor agonist, meaning that it will stimulate the receptor to stimulate appetite. So those trials, so again, 2 trials were done. They were called the Romana trials 1 and 2. Phase 3 trials look at how many sites and how many countries contributed to these trials. These are by far the largest trials in cancer cachectic patients ever. They randomized patients with lung cancer again, and with cachexia, meaning that they had already lost a bit of weight to start with. So advanced cancer that were studied here. Look at the numbers, huge amount of participants in those trials. They were followed during 12 weeks, after which the results were shown to be quite positive. So an increase in appetite was seen. This was evaluated with questionnaires that were filled by patients. Increased weight gain, increased lean mass. So that's, again, very positive, considering they were losing weight to start. So again, to switch someone who's on the declining curve to a upward curve is quite amazing. Increased quality of life, and unfortunately, the drug did not have, again, a major or significant effect on the test that was grip strength in that case. So again, that led to, well, I would not some, but a lot of disappointment. But in many experts' view, and myself included, I think that these trials are actually very positive in the outcomes that they provide. So again, on the patient's perspective, to be able to feel hungry again and to have the desire to eat and to be able to eat more has tremendous benefits on a day-to-day life, quality of life, and also for the caregiver of those patients who feel quite distressed to see their loved one not eating as usually. So you probably all know that eating should be something joyful, and when we have that feeling again, it's certainly very encouraging. So I'm not the only one. Many experts have acknowledged that that drug is actually provided the most positive and unprecedented positive outcomes ever, and of course more work is being done. Now moving on, lastly, to, again, a framework that shows the effect of the presence of cancer itself and the treatment leading to cachexia, and the different factors that are affected by these conditions. So again, food intake, physical activity that is reduced, and inflammation that is part of the picture. So having, again, this complex syndrome calls for an approach that should probably be also complex, meaning multimodal, which means addressing many aspects at the same time. So up to this point, most trials have either tested a single drug or have tested nutrition supplements, or some have started to test exercise. But to combine all of these together in a trial would lead probably to better results. So we've heard in practical clinics that's already being done, but there is a trial going on at the moment, which is called the MINAC trial for multimodal exercise, nutrition, and anti-inflammatory medication for cachexia. So again, a phase 3 randomized trial. It's open label. 5 countries are involved, including Canada and the Jewish General. It will follow patients with advanced cancer who are treated with chemotherapy. So the intervention is a combination of nutrition supplements providing more energy and protein with nutritional advice. So again, as we heard, the approach in nutrition should be individualized, and that's really part of the approach. Home-based exercise program, because not everyone can go to a gym and exercise with a group, so this is home-based. And lastly, the medication that is used here is an anti-inflammatory, Advil, ibuprofen, that is being tested, so for 6 weeks. And we don't have results yet, it's still ongoing, but the primary outcome, so the major change that they want to look at is a change in body weight and also changes in muscle mass and also physical activity. So this is generating a lot of hope. We are very anxious to see the results of this trial going on. And I believe that others will take place, testing different drugs, different nutrient formulation as well. So the take-home messages from all of this is that, again, muscle loss is a critical aspect in the cancer trajectory. We would like to be able to identify muscle loss very early on, not wait till we see it visually in a patient, but to be able to identify it early. We've seen imaging techniques that are very good, but they're not accessible to everybody, to every single patient. So the research drive here is to try to identify biomarkers, something we can measure in the blood, for instance, that would be indicating that muscle is being lost early on in the process. That would be an improvement. And finally, a multimodal intervention, so combining dietary intake, better nutrition, better physical activity and exercise with a good pharmacological agent is probably the best way to success as we think right now. So I would like to thank you for your attention, but I would also like to thank all the research participants who take part of these trials. I'm not involved in these trials, but I think that we need to thank them because they're really helping our understanding moving forward. And the funding agencies, and particularly the Goodman Foundation, to make this possible. Thank you.
Thank you very much, Tiffany. Our next talk will be a bit more on the molecular insight side. We'll hear about genes, we'll hear about the leading edge of research, we'll hear about HUR, I'm sure we'll hear a lot about HUR, and from a colleague here at the GCRC and on the campus actually in this very building. Thanks for coming, Imid.
Thanks, Thomas. Thank you. I'll try to be brief. Although it's hard to do a good job after these nice talks from Thomas and Stephanie. Really, even myself, I learned a few things. So the purpose of my talk is really to tell you what we are doing in a research lab to address this big question of cachexia. And Stephanie did a good job laying out the ground for my talk, because, I mean, one of the things that both Stephanie and Thomas said, that muscle wasting is really one of the hallmark of cancer cachexia. So when you have cancer, as you saw, you start losing the muscle mass, among other things. You have other problems, and you lead to muscle wasting, and that's a stage where things become critical and problem arises. So I'm not going to talk about all that. So the reason for muscle loss, that's the big question as scientists, as researchers we are tackling, we are asking the question. What we know is muscle loss is multifactorial. Many factors that causes muscle wasting. So, and that fact on its own poses a big challenge for us. Which pathway, which factors we can block so we can inhibit muscle loss? For now, we are still looking, but what we are doing, myself and others in the field, both in Canada and outside, is really lead us to hope, because we start now understand better the molecular mechanism behind muscle loss. So there are two aspects. The factor that comes from cancer, from the bloodstream attack the muscle, and what's happening inside the muscle. So one of the idea that we are working, basing our approaches for, is that we need to understand what's happening inside the muscle. At the same time, also identify factors that trigger the muscle collapse. So this is a summary that Thomas showed you, the various steps of cancer, of cachexia. where we have the pre-cachexia stage, the cachexia, and the refractory stage, and each one it's well characterized now, and we know it. So what we wanted to do as scientists is to identify biomarker, like Stephanie said, because as we speak now, the only way to diagnose cancer cachexia is when we have that DEXA scan and all our diagnosis where the patient starts losing muscle weight. We would like to identify that condition way before that. And the best way is, of course, the ideal test is to take blood, look for markers that will tell us this patient at some point will develop cachexia. The other stage, which I'm one of the scientists who was working on that, is to identify players that cause muscle collapse and understand what they do during the disease, then try to devise a new strategy to block them, to reverse the process, to block the process and reverse it. So here at McGill, long time ago, we started collaborating. We created collaboration through the Goodman Cancer Center, like Thomas said. This is a big, I mean, one of the best things being member of the Goodman Cancer is having surrounded by top scientists and have access to other scientists elsewhere, like in Montreal hospitals, and you can create really good collaboration that will be fruitful. So we applied long time ago with Simon Wing and Michel Tremblay and other colleagues for a fund from Terry Fox 12 years ago, and we were funded to do two things. One, identify early markers. That's what my colleague Michel Tremblay, Neil MacDonald, and others, members of the team, started doing long time ago. And just here I mention one of the findings they made recently, that they collected blood from 122 patients that have various cancers, and they looked for markers, specifically the pro-inflammatory markers that Stephanie mentioned, because inflammation is a big cause of muscle wasting. So they identified few markers, and they published recently a few years ago a nice paper showing that patients that they develop cachexia at early stages, they have high level of these pro-inflammatory markers. I mean, the names are not important, but just if you keep in mind that pro-inflammatory is important for the following talk. Myself, with my colleagues Simon and Jerry Peltier, we developed programs, each one in our labs, to understand the mechanism that cause muscle collapse. And we are still working in identifying those mechanisms. I'm going to present you a few of the observations that we are making in my lab, for example. And at least we are successful, and it's opening a big hope. Now, I told you one of the key players in muscle wasting is pro-inflammation. What is pro-inflammation? Inflammation is a defense mechanism that you all know. When we have a microbe or we have a foreign entity goes in our body, we have a response. And there are, of course, our immune system. And one of the main players in inflammation is the secretion of the various types of hormones that we call cytokines. And that's how our immune system reacts to foreign entity. Cancer is one of them. The problem with cancer is that tumor itself also becomes like a pro-inflammatory organ when it develops. Start also shooting these cytokines. So the level of these cytokines go from basic level, normal level, to high level chronically for a long time. And that's the problem. And that's what secretes some of these cytokines that are noted here, like IL-6, TNF-alpha, et cetera, and that's what causes the muscle wasting. So these cytokines go act on the muscle and trigger muscle loss. So here, just to give you an idea that these cytokines are secreted by cancer, they act not only on muscle, but affect the whole body and participate in that syndrome that Stephanie and Thomas, the Cachexia Syndrome. Now, when we look to the muscle, what happened is as soon as the muscle detected these high level of cytokines, trigger factors that we call cachexia effector or pro-cachectic effector. These factors inside our muscle fibers, they are activated and go and trigger the expression of many genes, and that's the only time I will talk about gene. So and those genes synthesize factors, and the muscle collapse and muscle loss starts. And this is, that's one of the effects, the impact of the activation of these factors. You have affect muscle integrity and function, decrease global protein synthesis, et cetera, et cetera. So in my lab, we've been interested for a long time in this process of pro-inflammatory cytokines that trigger muscle loss. One of these factors, as you see here, the TNF-alpha. TNF-alpha is a big pro-inflammatory cytokine that is involved in many things in the body, including during exercise help form muscle. And this is the irony in this disease. So the cancer almost modifies some of our good protein in our body and use them against us. One of them is cytokine, so TNF-alpha. So TNF-alpha triggers a mechanism that we call as scientists oxidative stress, and go and promote the production of NO, that is nitric oxide. I'm sure some of you heard about it. This is also another gas secreted by various cell lines or tissue in our body and is normally beneficial. But when it is triggered with high level of pro-inflammation, it produces toxic entity like a toxin we call peroxynitrite, and that's go and trigger muscle loss. A few years ago, my lab found working on something else, and we stumbled by chance natural products. I'm listing some of their names, and these natural products are able to block the process that produce this bad nitric oxide and prevent muscle wasting. Also in parallel, since we are in the business of understanding how muscle loss is triggered inside muscle, we found that HUR, that's one of my favorite proteins that I'm working on for 20 years. HUR also, again, it's a factor that normally is required to build muscle fibers in response to injury, to rebuild muscle that are destroyed, or in response to exercise. That's something we are testing as we speak in the lab. But we found that in response to high level of pro-inflammation, what happened, HUR switch its function and become bad, behaves badly and promote the production of inos and the bad nitric oxide and trigger muscle wasting. So that, since my lab is expert in HUR, or one of the many experts around the world in HUR, so we asked ourselves that does HUR really can be triggered, play a role in muscle wasting? So the data that we showed in our early study was done in the lab using tissue culture in the lab. So they are meaningful, they are indication, but they cannot be really have big meaningful to apply in patients if we don't prove that in a living organism. So what we did, we asked the question, does HUR play a role in muscle formation, muscle integrity, and muscle loss in an animal model? So of course we went to our big friend, the mice. Actually, mice should really get the Nobel Prize at some point because we use them for all sorts, as you know, and because of them we are finding really solutions to big problems, including cachexia. I hope that will help us. So what we did, we went with technology that really I will be happy to discuss later on, but it will be very boring. We were able to remove HUR expression, block its expression specifically in muscle in mice. So I told you earlier that we found there are many observations showing that HUR is important for muscle formation. So what we expected then that when we remove HUR from the muscle, we don't have even mice won't live. First surprise, that's research. That our mice that don't express HUR in their muscle, they're alive and healthy. So of course, we did this bunch of tests, and I'm going to show you one, is that we tested what happened in their muscle. What happened? These muscles, are they good? Can they behave normally? What's their features? So we did strength test, and so we put our mice in a treadmill. So, and our HUR knockout mice is on the right. The normal ones are on the left. And it happened, we found that our HUR that do not express their, mice do not express HUR in muscle, they have higher endurance. They run 10 minutes longer or more than the normal mice. So they have high endurance, and when we tested their oxygen consumption, they have higher oxygen consumption. They can release more CO2, and all that is a feature or what we call oxidative phenotype in muscle. Oxidative phenotype is correlated with marathon runner. So muscle, I don't know, maybe some of you heard about it. We have two types of muscle, the fast twitch and the slow twitch. So here in our data indicate that when we remove HUR, we promote the slow twitch in our different muscle tissues. And that had an implication in cachexia. Otherwise, I would not be talking about it today. So in fact, many papers showed that, in fact, cancer cachexia happen in the fast twitch muscles, which are the glycolytic muscle. Therefore, the oxidative muscles are the ones that the lack of HUR promotes them. They are protected against muscle wasting. So we said, if that's the case, so these mice that we generated, they need to be resistant to muscle wasting. And in fact, so we know how to do that. So obviously, one of our hope is that HUR, if that's the case, HUR become probably part of novel targets that we can use them or target them to prevent muscle wasting. So what we did, we took our mice that we generated without HUR, and we inject them with cancer cells. These are lung cancer cells taken from lung patients that we can grow in the laboratory, and we put them back in these mice, and they develop tumors within, they develop tumors within 30 days. And those mice that develop tumors, you see all the signs of cachexia that you heard about in humans. So muscle loss, loss of appetite, quality of life really bad. So what we tested is we followed the muscle weight of several types of muscles. Here, the quadriceps, the gastroc, the tibialis. So all these muscles have 10% or 15% or more loss in response to the tumors. And these are normal mice. However, the mice that do not express HUR or from which we removed HUR from muscle, they are all resistant. Their muscle are resistant, and they are healthy, and they behave really well inside the cage. So with this type of research, what we identified, it's a novel players that is a protein like the cachexia inducer, plays a role in many various aspects of muscle development, play a role, key role in promoting muscle loss in response to cancer. So this has given us a unique opportunity now to test whether we can generate drugs that target this protein. And of course, myself and my other labs are really working on identifying other targets to adopt the approach that Stephanie talked about. Because cachexia, we all believe that will not be cured with one target, with multi-approach treatments. One of them targets factors like this. So, and I would like to thank my lab. Some of them are here. Sergio Di Marco, who was the one who brought the muscle wasting project in my lab 15 years ago, and other members of the lab who are around, and my collaborators, among them Simon, who's with us, and of course, the funding agency. Thank you.
That's awesome. For our next portion of this forum is probably my favorite every time. We will try to understand what's the human impact of this aspect of cancer. And I must say that every single time we go through this process, we go through these testimonies, I hear amazing stories, very inspiring stories, and I honestly can tell that it made me think very, very differently about my research. So tonight we have Mr. Andrew with us, who's going to share his story, which involves, in good part, management of weight. Hi.
Hi, thank you for having me.
It's working now? Is it on?
Yeah, I guess.
Yeah. First off, again, thank you for being here.
Thank you for
It's
having
really
me
appreciated.
again. And it's been an honor.
Yeah.
to be
Well,
here.
you told me an amazing story, and I think it's great that you're here to share it. I'd like to start maybe with how you got diagnosed and how this big story started for you. Can you tell us a little bit about how you were diagnosed and how it went on from there?
Yeah, actually, it was on 2017. It was a challenging year for me. In the beginning, I started having pains in my chest, and then I was into the emergency, and then they just I had to go through a CT scan. Then they found there are so many lymph nodes in my stomach, more than hundreds of them. So in the beginning, they thought it was lymphoma. So after doing a biopsy, they found that it was a gastroesophagus cancer, a stage 4 cancer. So I was referred to a clinical trial in the beginning.
Yeah.
So after diagnosing, and then when I was put into a clinical trial called immunotherapy. Immunotherapy. So I had about 30 cycles on immunotherapy, but after the first treatment, I had side effect reactions. I got constipated and started bleeding internally. So I had to go to the emergency, and I got admitted. So at that point, I couldn't eat or drink. So I had pain in my chest, and it was hard to eat, swallow.
Yeah.
And then after I got admitted, so after about 24 hours, they found I was bleeding internally, and then I had to do a blood transfusion. So since I couldn't eat, they decided to put a peg on me. So while they had the peg in my, a germ got caught up. So unfortunately at that time, I was, after the first immunotherapy treatment, they had, all the doctors had thought it was a risk to have given antibiotics for me. But at that point, it was they decided they told me I will not survive more than 24 hours.
Yeah, and that's the turning point in your story, right?
Yeah.
You actually dig deep inside, and you had your family around you, and you said that in the end it ended up being a matter of fate.
Yeah. So actually, I asked one question at that point, I asked from the doctors are you all going to give up on me?
Yeah.
So actually, it was Dr. Jago and his team, and then they said that they're don't worry about the sickness, just have faith and just be strong. So I believe in God and I have faith in God. So at that time, I said that do whatever you all can to do, because I'm a father of two. At that time, my son was 2.5, my daughter is 1.5. So
it's a very good reason to fight. Hey?
Yeah. So I didn't want to give up, and I wanted to be just fight this. And I asked, they never give up on me. So I was really blessed to have the team, like Dr. Jago's team and like all the other doctors around me. And it was after just, I think it's about like 1.5 months I was in the hospital. And during that period, like I lost weight about like 20 kilos. I was 86, and like I lost down, like I went down to 65. So then like with the plan of Dr. Jago's team and all, like with all the help, like I managed to recover slowly. And then I continued 31 cycles of immunotherapy. So during that period, like they've been following up me very closely, and like I was doing my workouts, and I started working after 7 months also.
Yeah.
Like then I was like trying to eat healthy and like just keep my weight up, and then I gained back my weight like around like 72 and 73.
That's awesome. I mean, seeing
Yeah.
encouraging signs like this
Yeah.
after touching the bottom of the barrel is very encouraging, I imagine, right?
Yeah.
At that point, and actually now, you have a regimen that still includes exercise, treatment, and I think a close follow-up as well, right? Can you tell us a little bit about the ongoing treatment that you're going, which integrates all those elements?
Now, like I'm just switched to chemotherapy. So like it's since November. Like again, like after the first treatment, like I had very like weight loss. Like within 2 weeks time, I lost about like almost 10 kilos, because after the first chemo, I had like a lot of side effects. I had diarrhea and like nausea at the same time. Then they switched the medication. So then I started like gaining weight again, and then like I'm like trying to eat healthy, like drink a lot of water, and
you mentioned something along the lines of chemotherapy affecting taste as well and appetite, I guess, right?
Yeah, actually, like I had like lost appetite, and like my fingers getting numb,
Yeah.
and like I have to tingling, like so. So those kind of side effects are there. Still, like, but even though I don't feel the taste, like I try to eat something, but I feel hungry. Like so, like I always try to keep eating. So like try to like break, just sometimes like there are days that like I don't have the appetite, but like I try different things.
Yeah.
So like some days like fruits or just some other stuff, like I try to have all kind of foods, like different varieties. So that's how I like just I try to keep the weight balanced, and also I just try to do exercises.
Yeah,
like
that must be difficult some days, I guess.
Yeah, there are days like in the beginning of the chemo, like the first 7 days, it's really hard. Like it puts you down, like so it's very difficult, and just. Somehow I just, after about 7 days, I try to keep up, like just do the workouts. So when I do workouts, I feel hungry more. So like that's how like just I eat and then like go on.
Yeah.
So
that's an amazing story, and thank you for coming and sharing. Is there maybe one message you want to throw out there to anyone actually undergoing a muscle loss or weight loss during treatment or because of cancer? Is there some message you want to leave to the audience and people watching this?
Yeah. Like what I wanted to say is, no matter what comes in life, never give up. So like there are wonderful people around us, and like just give a helping hand to one another. So just to so like we can, like we're all together. So like every people had different issues every day. So whatever the issues is, like just it can be a cancer, it can be other issues in life. So no matter what comes in life, like you should not give up. So that's how I live every day. So I'm trying to take one day at a time, but like I have hope and faith. That's it.
All right. Thank you very much for sharing. We appreciate it. Thank you. Very inspiring. All right. So the last portion of the forums, as you know, is actually a round table where we answer all of your questions. Actually, we try to answer all your questions. I forgot to mention, but we have actually an extraordinary panel. This time we have additional members that are part of the collaborating teams. You already heard from Dr. Jago, Chevalier, and Galuzzi, but they will be met tonight, and the panel will be completed by really stellar participants, including Dr. Simon Wing, who's a professor at the Department of Endocrinology and Metabolism and Department of Medicine, here at McGill, and is also the leader of the Metabolic Disorder and Complications Program Research Institute at MUHC, and also by Christina van der Broek, who's a dietitian, and here at in the program of Cancer Nutrition and Rehabilitation at the Jewish General Hospital. So we really have a complete panel, and you have received those cards. I hope some of you ask questions. And the volunteers are in the back here. We have one here. They are showing their hands. So just lend your questions to the volunteers. They'll bring back the questions in front, and we'll go on as a panel, assemble and answer your questions openly. All right, so a few minutes so you can write them down, maybe 5 minutes, and we'll gather them in front. If the panelists would like to join us in front, it'd be great. Let's start. You ready? Thanks for being here again. And here we go. So does immunotherapy cause muscle loss? Who wants to take it? There's one microphone. We can pass it around. But who want to take this one?
The short answer to that is no. But there are some complications that occur with immunotherapy where you can get a sort of a condition which is like some of the autoimmune diseases like rheumatoid arthritis and related syndromes. So certainly it's not a common muscle wasting. Muscle wasting is not a common problem with immunotherapy, but it can happen as part of a complication syndrome, which we see in a small proportion of patients.
All right. Is immunotherapy an induced inflammation because of the immune response? Do we actually induce an inflammation when we use immunotherapy?
Yeah, that is a good question. Certainly, you see increased inflammation or an increased inflammatory response around the tumor itself. And you can also see a flare-up in inflammation, and that's why people that already have chronic inflammatory conditions, whether it's chronic inflammatory bowel disease or arthritis or other problems, are actually contraindicated to have immunotherapy. So the answer is yes, it can. In practice, it doesn't generally lead, if you haven't got those previous conditions, it doesn't generally lead to a sort of increase in generalized inflammation. Yeah, the question is well put, that it can promote inflammation in certain circumstances.
Very good. For treatment of cachexia, what are the home-based initiatives like the ones that could be practiced by patients? In other words, what can patients do at home if they really want to do more? What can you do?
Hi, I'm the dietitian on the Cancer Nutrition Rehab team. Often when we see patients who are losing weight, our first thing that we're trying to do is to help them to stabilize weight. And the thing that we speak about the most is trying to increase calorie and protein intake. So that's what I talk to my patients a lot about, is ways to increase their total calorie and protein intake. So as Dr. Jago mentioned, often when patients come to see us, they're not actually having an adequate intake. So obviously it sounds straightforward, just increasing calories and protein, but it's a very individualized plan for each person. Obviously, patients will have many different symptoms, and so we take that into account also and try to individualize the plan.
Okay, thanks. Pre-cancer-wise, does exercise have any protective or preventive effect against the subsequent cachexia? Does someone who does a lot of exercise pre-cancer, does it protect against developing cachexia later on when you have cancer?
It doesn't protect against the metabolic changes that are induced by cancer, but it probably means that you're starting at a much better baseline level, and it's actually easier to correct with the appropriate intervention. So I don't think you can really characterize it as a protection in the sense of it stops it happening, but it certainly sets you up to be stronger from the get-go, and so any deficits are probably easier to correct.
So the answer is, I guess, yes, but not an absolute yes.
Okay. Yes.
Okay. Any idea why pancreatic cancer leads to the greatest weight loss? Why pancreatic cancer leads to that? Anyone? Thomas?
We don't know, but there is at least the pancreas, the function of the pancreas, where it is in the body, and the type of reaction that's set up, so can lead to a sort of perfect storm of problems. Some of the cytokines that Imelda talked about, particularly in one sort of pancreatic cancer, are very, very, very high, and that can promote a whole bunch of different changes. But also the pancreas has a function which is to help with absorption of nutrients, and so some people actually present with advanced cancer, but also a huge difficulty actually absorbing the nutrients that they're trying to eat. So they've actually got problems at a number of different levels, and I think that promotes it. And the other thing perhaps is, like a lot of cancers, it seems to be one that is silent and it's not showing itself until quite a late stage. And so, unfortunately, I've seen many people who've presented very late with very severe disease, and they didn't know about it really until very late in the whole process.
Simon, you want to add?
Also, there is some studies that suggest that pancreatic cancers can make specific factors which can go out into the blood and promote muscle wasting. And again, for reasons that aren't that clear, pancreatic cancer is associated with what Dr. Chevalier mentioned, insulin resistance, where the insulin, which is produced by the rest of the pancreas for reasons that are not known, doesn't work as well, or it's not as secreted as abundantly.
I guess this partially answers the other question where they ask essentially, different type of cancers, would you treat cachexia the same way, or would you expect different response with different type of cancer leading to cachexia? Is cachexia responding to the same strategy if you have different types of cancer?
At the moment, we don't have a very sort of individualized program for different cancers. I hope that in the future, as this field develops, that we may be better at distinguishing different patterns related to different tumors. I have to say, the way that oncology is going, we're getting more about not talking about different cancers, but we're talking about different reactions or different the similarities actually between different cancers. So there may well be different approaches that we evolve and develop over the years. I'm not sure that they're going to reflect specific cancer types. They may reflect different ways that individuals respond to the same problem.
All right, so another question, I guess, that can be answered maybe by Christine. Is a nutritional supplement or tube feeding formula appropriate nutrition when there is no appetite?
It's not our first line. It's not the first thing that we do. Obviously, we try to meet a patient's needs with oral food, and when we fail to do that, then we will consider also taking oral nutritional supplements. But our first line is not to go to enteral or parenteral nutrition. It is an option, but usually, for example, parenteral nutrition would be if the GI tract is not functioning. Enteral nutrition, in some cases, for example, a patient who has head and neck cancer and has severe dysphagia and cannot eat orally, well then, yes, that would be the way that patient would be fed. So it really depends from one patient to another. But someone whose gastrointestinal tract is functioning, they don't have dysphagia and are able to eat orally, that is the approach that we take.
I see. When people cannot swallow, for example, right?
yeah, for somebody who has difficulty swallowing, again, it would be to what degree. Some patients have dysphagia, and it's just a question of needing to modify the texture of their diet or the thickness of the liquids, and they're able to continue eating orally. But yes, in some head and neck cancer patients, for example, it's just not possible for them to be able to eat or drink orally. In that case, those patients will often get a PEG or get a tube feeding, and that's how they'll be fed, at least for the short term.
I see.
Yes.
This next one is probably for Stephanie. Not sure, I'm betting on you. So, given the positive results with the type 2 diabetes drug rosiglitazone in rodent models of cancer cachexia, do you have any interest in trying this with cancer patients? Do you think it justifies clinical trials?
First of all, I have to admit I was not aware of the efficacy of rosiglitazone in cancer cachexia.
Well, that's what it says here. So we have an expert somewhere here, I guess, right?
Are you?
Okay, oh, very good. Okay. Do you want to address this with the microphone, or?
In rats, rosiglitazone has been used specifically to overcome insulin resistance.
Yes, for sure. That's very well demonstrated. Even in human beings who have type 2 diabetes, that's a useful drug to stimulate insulin action in tissues like muscle and adipose tissue that are normally sensitive to insulin. I don't believe that it's been tested in cancer patients, but probably.
I think you're right, but given that it's such a
Right. Well, the same would apply, I would add, to metformin, which is also a drug that will reduce the production of glucose by the liver and will increase glucose uptake by the cell. So it will help that. Metformin has been tested not tested actually, but the use of metformin in some cancer patients is shown. I don't think that at this point it has shown striking results, if I'm not mistaken. But rosiglitazone, I don't believe that it's been tested yet.
Just to add an answer. So I don't know particularly this drug, which I heard about, but what I can say, for example, we tested metformin. Metformin at best does nothing for cachexia, at least in animal. However, we tested a homologue of metformin, which normally it's used target the same molecule that is targeted by metformin, but we found out that the molecule we used, the way you activate this energy sensor inside the muscle or inside the cell will determine the outcome. So if we have a direct activator, that metformin does not do that, because metformin affects the machine that produce energy inside the cell, act on indirectly. So this idea of tackling the same players in type 2 diabetes, I can tell you that's, at least we have evidence in mice that works, but it's not the classic drugs that we are talking about. It must be developed a new family of drugs.
All right, a question regarding the importance of age on the effect of remission. A patient, someone here wants to ask, age at the start of remission, is it a critical factor for the impact of remission of cachexia? Does it, I guess the question is, does age, when you discover you have an effect of cachexia, does it have an impact on your chances?
Certainly from our approach, it's not, there isn't a sort of cutoff, there isn't an issue in terms of doing the sort of things that we do. Age really doesn't come into it. It may change, I guess, the goals that we may have, and we may, I think, try and be realistic about what somebody who's 85 can do versus what somebody who's 36. However, as Stephanie, I think, hinted at, that we do know that there are natural changes in muscle, for instance, and perhaps other aspects of metabolism which occur with age. And after the age of about 65, 70, for instance, well, actually after 50, but after certainly as you get into the 70s and 80s, you can't sustain the same muscle mass that you can when you're 30 or 40. So I think it doesn't change the approach, but I think there are some age-related barriers that we can't get around related to how strong and fit we can make people.
You want to add something, Sam?
Yes, I would just support that in the sense that with age, muscle mass does naturally decline, like many things do in our body. And part of that is probably related to, for example, changes in hormonal milieu, like levels of testosterone, which are an important player of muscle mass in men. They gradually decrease with age. And also people develop gradually more insulin resistance with age too. So.
Okay. So this question regards Anamira. So I guess it relates to your the clinical trials you presented. What were the side effects of that drug?
That's very interesting. There were little adverse effect within those trials. The one that was mostly reported as the most common one was hyperglycemia and more diabetes in, if I remember correctly, less than 2% of participants. So the next level of side effects were gastrointestinal types of side effects, nausea as well, and constipation, diarrhea. It always depends. That's highly individual. But these are the main ones reported, which is quite weak in terms of side effects compared to other drugs that have much more severe types of side effects.
I see. Thomas, you wanted to add something?
Just to reinforce what Stephanie is saying, that generally speaking, it seemed to be very well tolerated. It wasn't something that came with a lot of toxicity, but there was some. Yeah.
Okay. A question regarding BMI. So if you have a low BMI, you may still have good muscle, right? So the question is, why is low weight bad if you can still have good muscle at low BMI?
Well, at a very low BMI, you don't have a lot of muscle. That is just impossible. So in proportion, muscle may take a lot of your percentage of body weight, but at a low BMI, if we talk about BMIs of 18 or lower than that, you don't have a lot of muscle. So that's why it's a risk factor from the beginning, having a low BMI for prognosis.
All right. Thanks. This question has to do with stem cells. So the question is, have you or anyone ever considered using stem cells injection or stem cell therapy in cachexia? Yeah.
So I think that's a very popular approaches, but what we know from at least some studies have been done recently in the last few years where the satellite cells, which are the equivalent of the cells that from which muscle originated, the cachectic condition affect them too. That's why if we find solution of not only stop muscle mass, but reactivating the niche of satellite cells that we have, that could be a viable approach. But so far, as far as I know, that's not a viable approach.
Anyone? Anyone else?
Yeah, I mean, just to clarify that we are still discovering stuff that's going on in humans that we didn't know about and we didn't really guess about either. And one of the things that seems to have come through in the last few years from biopsies from humans is that muscles have, as Ahmed was saying, and muscles have their own satellite-type cells, and those are very important for repair of the muscle. And there seem to be quite a lot of them, in fact, perhaps more, but they don't seem to be able to repair the muscle. So it's not a question of giving stem cells to help cachexia. It's going to be a question of how can we help the stem cells that are there work normally or more effectively than they are now, because it looks like there's a problem that we didn't even realize was there with how they function.
All right, so from the presentation of Ahmed, so Ahmed, it's probably for you. Can we conclude that endurance, it's a really good question actually, I think it's really cool. Can we conclude that endurance training is better to fight cachexia? However, endurance training doesn't mean a lot of muscle mass. When you train, like for a marathon, you don't have a lot of muscle mass apparently. So the question is this really better to treat cachexia?
So that's a really terrific question. I don't think I have complete answer, but from what I know, is in cachexia, what my colleagues can answer, correct me, it's not the muscle volume that matters, it's the quality of the muscle you have. And obviously one thing that endurance muscle type that favor endurance are muscle that can resist, can let you resist to activity, to have a better quality of life. So in fact, I mean, and exercise, however, like Thomas said earlier, if you are starting to exercise where you have a cachectic condition, you start already from a low level of your muscle are suffering. So you need to bring them to a certain level, then you can start type of exercise like endurance. But what we are hoping is to favor more your muscle fibers type. I mean, when we find the treatment, if one day we find sort of treatment that will favor those oxidative muscle that I talked about, and that will give you probably more protection against muscle loss. At least that's how we hope to stop that.
I guess no one pretends that they'll start training for the marathon once suffering from cachexia.
I mean, another question as a follow-up to this, is marathon runner who develop cancer will be more protected than somebody else?
Another
That's
trick.
Up for, we'll see. Yeah.
Anyone you want to add on that or not? Okay, good. So you have talked about identifying cachexia early. How can you do this? How can you actually look for early markers?
That's $1 million question. And who will find it? I think they will be Nobel Prize winner in my book. So how you find it, this is the tricky question because there are many factors that collaborate at the same time, come in the bloodstream and trigger cachexia. So it's not one. So, but the study that are made by many laboratories is really to go after the pro-inflammatory cytokines. So if we can have a connection, enough patients that we can follow, and we have a connection between increase of a family of those cytokines and development of cachexia, we can have at least an early guess. Now from there to have a solid early diagnosis, probably we are still a few years far from that, but that's the hope.
Early markers, anyone? Takers? No? Good? Yeah? No? Okay, so this one is more about what happens in the clinic, right? Also, a cancer patient undergoing weight loss, do they need to ask for intervention or are they directed to an intervention?
Well, for our program, the Cancer Nutrition Rehab Program at the Jewish General Hospital, when patients need to be referred to our program, they're usually referred from their treating team. Sometimes we do have patients also who know about our team and then ask to be referred to our team. So it's usually on a referral basis.
That's my own though. What's the threshold? Do you wait? You have a certain threshold of 5%. Though clinicians actually have a threshold detecting this person has lost 5%. Therefore, we need to. What's the practice?
We don't have a threshold. Basically, anyone who's experiencing weight loss, decreased appetite, or decrease in function can be referred to our team.
And a patient can initiate it on their own also.
We do have patients definitely who do know about our program and who will ask their oncologist to be referred to us for sure.
Good.
I would just add that it sounds like everybody's got a comment, but this is a message to carers, to patients, that you should ask for help because the oncologists have got an increasingly complicated job with a huge number of different things, and their focus is on the cancer, and sometimes we find their focus is not on the other things that are going on. And so I think it's one of the messages from this sort of forum and elsewhere is to try and empower patients and people who are caring for those patients to ask for help, to ask to get referred, and to say, look, is there somebody who can help with this problem? Because we see people, too many people too late, unfortunately.
Well, it's just a follow-up on this. Actually, these persons are being very modest in what they do because they do incredible work, but they're a small team and they cannot see all patients. And I would argue that ideally, in an ideal health system world, we should not wait until we see signs of cachexia. We should actually be able to at least counsel with every single cancer patient that goes into an oncology ward, and there's not enough dietitians in hospitals to do that, and there's not enough kinesiologists or physiotherapists or nurses to do that, which I think is a problem, and that's a plea to hire more.
Simon?
Want to talk about prehabilitation?
Well, that's one thing that we can also consider, which is a concept we talk about and we call prehabilitation instead of rehabilitation. So for instance, cancer patients undergoing surgery could actually enter another kind of program that is kind of similar taking place at the Montreal General Hospital. And that program will take opportunity of the waiting time between the diagnosis and the time of surgery, which is usually a window of 4 weeks of waiting time. And during that time, instead of stressing out and being anxious waiting at home, that program helps patients undergoing exercise program, nutritional advice, supplements if needed, also some anxiety management sessions. And this has been shown to actually increase your functional status before surgery, and that could help recovery after, having a faster recovery. So these kinds of approaches are quite similar, but again, still too small in terms of programs. They need to develop and see much more patients. Yeah. Thank you.
All right. So 2 more questions. Can BCAA supplements, branched-chain amino acids, help to fight cachexia as a supplement?
I can take this one. So branched-chain amino acids, one of them in particular is leucine. Leucine is one of, so amino acids are the building blocks of proteins. We need them to build new proteins, so that's why we need to eat proteins. Some of them we cannot, some of those amino acids we cannot make ourselves. We need to eat them from the diet. So one of those BCAA is leucine, and leucine is not just a building block. It's also an amino acid that will signal, that will tell the cells to synthesize more protein. So that's really interesting, and there has been some studies with using oral supplements, highly enriched with branched-chain amino acids, or even patients who have to go under parenteral nutrition, so nutrition through the veins, with solutions containing more branched-chain amino acids. There are small studies that have shown some modest benefits, but at the moment it's not something that is, again, striking. So I would more suggest to go for being able to ingest more protein in general, good quality protein from the diet, as Christina mentioned, if you're able to just ingest more. Sometimes it's just little tricks to sort of break down the meals into smaller meals, but always containing a source of protein that could be helpful.
Okay, a question about lasers now. You ready? Low-intensity laser irradiation has been proven to stimulate cellular proliferation. Is there any study using that therapeutic approach? Anyone? Lasers?
I don't.
No. So sometimes we don't know, right? So that was the last. There are actually a few questions that were more on the personal side, personal cases, people that were diagnosed or have a very specific situation. You're welcome to join afterward to ask those questions. It's more of the personal level. I have one for you. It's not the audience, it's me. Shouldn't we systematically try to eat more protein, eat more carefully, and actually do exercise as soon as we're diagnosed as a preemptive measure? I know we hear a lot about that, and it's sure not easy when we're treated, but what you're proposing is to start using this once we're cachexic, but is there actually a preemptive strategy there that's valid?
Well, so exercise more is always good. No question there. Eat more protein, it depends where you start from. So if you don't eat a lot to start with, yes, I would tend to think that it's a good idea and it's not harmful. If you eat a lot of proteins, some people do. In general, we don't, but some people do. Maybe that's not useful in that case. So it depends, again, where you start.
Where your background was. Okay. We're right on time. So thank you very much to the panelists, and thank you for the questions also.